Hello, good afternoon, everyone. Welcome to today's PHSR Research in Progress webinar series. And today's research theme will be covering public health costs, quality, and value. And we'll be having, actually a treat today, we'll be having two presentations. One is a public health service cost study that covers tobacco prevention, and another that will be covering environmental health services. So we're pretty excited and we welcome everyone. And before we get started, we just wanted to go through some logistics as a courtesy to our speakers and our presenters. Please do mute your phone, microphone, and computer speakers during the presentation so as to avoid feedback. And also, you could download today's presentation and speakers' bios from the Files To box at the top right corner of your screen. So, given that we have two presentations today, I'll be your moderator for this afternoon. My name is C.B. Mamrell, and we're excited to have with us presenters from our New Jersey Public Health PBRN, Pauline and Susan, and presenters from our North Carolina Public Health PBRN, Nancy and Simone. And so each of them will be giving 20-minute presentations from each of the PBRNs. And this will be followed by commentaries from Lisa Harrison from the Granville-Vance Health Department, North Carolina, and Kevin Sumner from the Middlebrook Regional Health Commission, New Jersey. And hopefully we'll still have time at the very end of this webinar to open the floor to questions from the audience. So these two studies are part of the National Coordinating Center's Research Grant Award, known as the Public Health Delivery and Cost Studies, or DACS for short. This was a research grant award with support and funding from the Robert Wood Johnson Foundation. And these studies are part of a national initiative to really get to the value of public health services. And so these studies identify the cost of delivering high-value public health services. They evaluated the influence of delivery system characteristics on the effectiveness, efficiency, and equity of these services. They developed and applied cost estimation methodologies in various practice settings, in a wide range of practice settings actually, and they generated novel empirical results to inform policy and decision making. So there were 11 PBRNs all in all that were involved in these studies. 3 of them carried out 12-month studies, and the other 8 carried out 18-month studies that involved larger comparative methodology. So for those who are interested in finding out more, you can contact the National Coordinating Center, or you can also access the link that's provided to the website at the National Coordinating Center. So without further ado, I'm going to introduce first the speakers from our presentation from the New Jersey Public Health PBRN. We have with us today Dr. Pauline Thomas, who's an Associate Professor of Preventive Medicine and Community Health, and also Director of Residency in Preventive Medicine and Public Health at the Rutgers, New Jersey Medical School. Also with the Rutgers, New Jersey Medical School is her co-presenter, Susan Gurman, who's a research associate with Preventive Medicine and Community Health. So we welcome you, Pauline and Susan. We're excited to hear your presentation, and I will turn the floor over to you guys.
Thank you, CB. We are going to talk about determining the public health costs of tobacco prevention and control and comparing 4 New Jersey local health departments. As you said, I'm here with my colleague Susan Gurman, our research associate. Anushu Sinha is the researcher who advised us on costing analysis. Kevin Sumner, health officer consultant to the project, is also with us today, and other health department folks who participated: Nancy Raymond, Judith Migliaccio, Corin Norwood, and Pascal Nwako. And we also had a consultation from Natalie Palenko, who was our New Jersey Department of Health participant. And this was a project of the New Jersey Public Health PBRN. So we selected tobacco for our DACS study because it is the largest preventable cause of disease and death. And after a long decline, New Jersey adult tobacco smoking rate has plateaued. New Jersey revenue for tobacco use prevention and control has been redirected, and that includes redirection of tobacco sales tax generated revenue as well as master settlement funds. And CDC recommends $2 to $3 per capita for New Jersey tobacco state and community interventions. That's one of CDC's 5 components for tobacco control, and we chose this one as our benchmark for our project. So some background on New Jersey. New Jersey has 89 local health departments covering 566 municipalities, and this number of health departments is shrinking as they merge and combine efforts. All are units of local government. Over 50% of their revenue is from local sources. Our health departments have 4 jurisdictional structures. 30 are municipal, 35 are interlocal or contracting, meaning one local health department provides services to the others. 19 are county-based health departments, and we have 5 regional health commissions. Our objectives were to determine elemental and total costs of local public health activities comprising tobacco prevention, reduction, and control, and to contribute to the understanding of costs involved in delivering efficient and effective public health services. So as I noted, this was a PBRN-based partnership. We had co-investigators from the New Jersey Department of Health, local health departments, and Rutgers. The New Jersey Department of Health sent out a call for interest to all of the 89 local health departments. 15 volunteered to participate, and from those we selected 4 for diversity of their population, geographic location, and administrative structures. The 4 participating local health departments included 2 municipal, 1 regional health commission, and 1 county. And we provided a $500 gift card as an incentive to the participating health departments. This shows a map of New Jersey, and the blue stars represent where the health departments are. The 2 are municipal. One was a small municipal, 15,000 people, and then another municipal, the regional health department, had 43,000 people, and the county health department was, of course, the largest with 500,000. So we collected data through key informant interviews. First, we developed lists of activities, including an inventory of tobacco prevention and control activities, and a component breakdown for each activity, including labor and non-labor resources. We then developed cost and labor data, quantifying resources, specifically personnel hours, supplies, equipment, transportation, and facilities, and determined a unit cost for each resource, which would be multiplied by quantity to estimate the overall cost for that resource. The interview forms were adapted from the Substance Abuse Services Cost Analysis Program, or SASCAP, which was developed by SAMHSA and RTI International. And I'm going to turn it over to Susan for the more technical aspects of the analysis and methods. Susan.
Okay, thank you, Pauline. So I will now just review our methods and some of our findings. So our perspective is local health department, and I will note that we also added opportunity costs for volunteers and facility costs. Our time frame was calendar year 2013. We used a retrospective cost accounting approach. And again, as Pauline mentioned, we estimated costs for resources by multiplying the count of the resource by the unit cost. And all of our costs were expressed in 2013 US dollars. This is just an example of a time allocation table in our interview form. There's a table such as this for every activity up to 15 activities. The columns across the top are the component breakdowns of the activity, and then the rows on the left are all possible job types that might perform the activity, and then in the boxes in the grid would be the time spent for each component activity. Okay, just to review our data sources. Our activity inventory and breakdown were produced from key informant interviews. We had mixed source cost data from the interviews, which included expenditure reports, price lists, payroll databases, and budgets only where needed. We preferred expenditure reports as that's the amount actually being spent. Our facility opportunity cost estimation was estimated by the average office asking rental rate per square foot for the county where the LHD resides. Our volunteer labor opportunity cost was estimated by the average wage for each volunteer's respective profession. And our denominator values were from the U.S. Census 2013 Population Estimates Program. And this slide just shows some of the activities and the number of LHDs performing those activities. You can see that the only activity that all 4 sites performed was policy development, and 3 that only the county performed were implementation of tobacco cessation, dissemination of educational mass media, and tobacco use surveillance. And here we just have total tobacco activity and costs by local health department. And you can see that the number of activities range from 2 to 12. The county performed 12 activities. And the total costs ranged from about $1,700 to over $400,000. And the per capita costs range from 4 cents to 79 cents. And this slide just shows for select activities the per capita cost. You can see that policy development had the highest cost. Hard to see on this is for the A's, which is a tobacco age of sale enforcement. The county actually had less than 1 cent per capita cost, but it is there. And here we just have the cost structure by LHD. And for all but the county department, it's about 80 or more % labor. The county department has a very large facility, so their ratio is about 50-50 between labor and non-labor. Okay, so we also added in the state expenditure for tobacco control. The state level per capita spending for fiscal year 2013 was 40 cents. This is mostly from federal funds. The only state funded for state expenditures is the retail license fee. So most of the funds for state spending are from federal sources. So adding this 40 cents to the LHD per capita costs results in just 44 cents to $1.19 per capita. Okay, and here's just a visualization of the gap between what the state and the local health departments are spending and the minimum level that the CDC recommends for New Jersey spend per capita. The gaps range from 145 to 220 that would be needed in order to reach the CDC minimum level. And I will now turn this back to Polly, who will discuss our conclusions, limitations, and other wrap-up issues.
Thanks, Susan. So as Susan just demonstrated, none of our 4 local health departments met the CDC recommended annual per capita allocation of $2 to $3 for New Jersey state and community tobacco interventions. Our data demonstrate insufficient resources for local health departments to confront the leading cause of morbidity and mortality. We have several limitations. Local health departments do not maintain labor data in the component-based format used by SASGAP. time-intensive data collection is difficult for these health departments. While local health department staff were supportive and enthusiastic, they lack time resources to participate easily in public health services.
Yeah.
There's possible measurement error due to retrospective and self-report design, and our data do not include non-governmental tobacco control efforts, for example, partner activities. Some of the health officers do consult to community partnerships, but don't give that much time, and then the community partnerships do some tobacco control activity. Implications for public health policy and practice. We hope these data will be used to advocate for additional resources where the CDC recommended per capita funding for tobacco control is not met. This adds to public health knowledge of mechanisms through which costs, information, and labor produce public health promotion and protection services, programs, and policies. Finally, elucidation of the true costs of local tobacco control is needed to attain the goal of delivering foundational public health services at the community level. And finally, our next steps, we are going to conclude our data analysis, share findings with our local public health practice-based research network partners, and prepare a manuscript for publication. And we just want to acknowledge the Robert Wood Johnson Foundation, University of Kentucky, and our local partners. Thank you.
Thank you.
Thank you, Pauline. Thank you, Susan. And thank you to the New Jersey PBRN DAX research team for that presentation. We'll be having, after the North Carolina PBRN DAX research team provides the presentation, we'll also have commentaries on the presentation that we just heard from New Jersey. So before we move on to the North Carolina presentation, I'd just like a reminder to everyone, as a courtesy to our speakers, please kindly mute your phone microphones and computer speakers so as to avoid feedback. So our next set of presenters, we're happy to have them with us, is from our North Carolina Public Health PBRN. We have Dr. Nancy Winterbauer, Assistant Professor at the Department of Public Health, East Carolina University, and her co-presenter, Dr. Simone Singh, who is an Assistant Professor at the Health Management Policy School of Public Health at the University of Michigan. So I turn it over to you, Nancy and Simone, and you have the floor.
Okay, thanks, CB. Hi, everybody. We're happy to present today on our North Carolina Public Health PBRN DAX study, which was titled Developing a Tool for Estimating Local Health Departments' Costs of Providing Public Health Services. And the purpose of our study was to determine what it costs to provide the mandated public health services. And this research question actually came from our practice PI, Lisa Harrison, who's on the phone and will be commenting later, who, upon taking over as the health director at a multi-county health district and was new to her job, was, I think, originally frustrated in just trying to figure out what things cost. And she may have more to say about that later. In terms of background, I'm sure most of us know it, little is known about the cost of providing services in local health departments, and understanding the factors that contribute to cost are really necessary for demonstrating the need for funding, for programmatic decision-making, and importantly, for achieving efficiency in public health interventions. Our specific aims were to estimate and validate the cost per unit of service for selected services, construct a validated methodology for the estimation of service costs, and examine the influence of different delivery system structures on the cost of delivering the mandated and other essential public health services. Our first task, together with our practice partners, was to determine which of the mandated services in North Carolina we would end up costing, and we finally decided on food and lodging and on-site water. And we concluded with these services essentially because of data availability. For our cost estimation methods, we relied first on empirical data That was administrative data that's reported to the North Carolina Department of Public Health. North Carolina has 100 counties and 85 local health departments. The second method was the SASCAP tool, which New Jersey described earlier, and we sought that data from 16 local health departments, and then finally a time log approach where, as they talked about in New Jersey also, we collected activity logs for specific health services. We're going to focus some of the method discussion on the resource-based method that we used. So again, the tool was based on the SASCAP, which was developed by RTI. It has two modules, a cost module and a labor module, and that tool was adapted for this study with a lot of interaction with some of our local health department partners, a lot of iterative design and redesign there. And in our survey, both of these modules were combined into one tool, and for each service, the tool asked respondents to indicate the number of services provided, direct labor costs, other direct costs, and indirect costs. To date, 15 of the 16 local health departments have completed the tool. We are still waiting for one, but we think we're going to get it soon. Respondents have usually included the finance officer and the environmental health manager or other environmental health staff, and the time required to complete the tool has ranged from 2 to 12 hours with a median of 4 hours. All local health departments received probably multiple phone calls from my long-suffering colleague, Ashley Tucker. It was a very intensive process, and as New Jersey noted, it was really required quite a bit of time from some of the health departments. In terms of our participating counties, we tried to get a heterogeneous sample with diverse local health department types and different regions of the state, but it was not random and was essentially based on willingness to participate. We looked at the characteristics of our participating local health departments and compared them with the total North Carolina counties overall. Essentially, the small and medium-sized population counties were overrepresented in our sample. The eastern counties were underrepresented and the western counties were overrepresented. Population density was not too bad, but the very, very small counties were not represented in our sample. And the percent rural matched up pretty well with the state characteristics. And so now I'll turn it over to Simone.
Thank you, Nancy. So let me present a couple of the key descriptive results from our survey data. So for fiscal year 2012, which is the year that we chose for this study, the LHCs in our sample provide a median of about 2,400 food and lodging inspections. The number of FTEs, full-time equivalent staff required for providing these services was 4.5. And so you can see that in the rightmost column, that translated into about 500 services provided per FTE in that year. Similarly, you can see for on-site water and well inspections, there was a median number of services of 5,700. Again, the number of FTEs was 4.5 at the median, and so in terms of productivity, each FTE staff provided approximately 860 services in that year. You can see that there was a fair range, a fair bit of a range in terms of number of services, but also FTEs, and then in terms of productivity across health departments. So moving on to some of the cost results. Based on our survey, we computed the total cost of both food and lodging and on-site water and well services. You can see median total cost was about $288,000 for food and lodging and about $347,000 for on-site water and well inspection services. So that translated into cost per service of around $145 at the median for food and lodging, compared to $82 per service for on-site water and well inspections. And then we also looked at the cost per capita. You can see that in the rightmost column, the cost per capita was about $3.40 for food and lodging compared to $4.40 for on-site water and well inspections. Again, you can see in parentheses, there's quite a range in terms of total cost, but also cost per service and cost per capita. And I didn't show this here, but we did look into sort of the correlation across the two service lines, and what we saw was, or what we found was that health departments that had lower cost for providing food and lodging service also tended to have lower cost per service for providing on-site water and well services, and vice versa. So the more efficient health departments in one service line were also more efficient in the other. And the opposite held true as well. So what are some of the cost elements that these total cost figures are made up of? So similar to what Susan described for the New Jersey DAX study, we also found that labor accounted for approximately 80 to 85% of the total cost. Other direct costs, including rent, which was also measured using an opportunity cost concept, supplies, subcontracts, and other travel and other miscellaneous costs, accounted for about 10 to 15% of total cost, and then the remainder, approximately 5 to 6%, was indirect cost. So what that shows is that at least for environmental health services, and obviously also for other services, as we heard from New Jersey, what really drives costs in public health is staffing. All other costs, at least in our example here, were fairly minor compared to the personnel costs. So what that also shows is that most LHDs have a fairly large amount or a large proportion of fixed costs, as staffing costs are usually fixed, at least in the short term. And therefore, there's a potential to enjoy benefits of economies of scale, that is producing more services, with a certain amount or a certain workforce. And so we looked a little bit more into this, just doing some binary correlations and graphing this out. We looked at the relationship between the number of services provided. You can see that here for food and lodging, the number is on the x-axis, and then we have on the y-axis the cost per service. And you can see there is a fairly strong negative relationship between the two. The same holds true for on-site water and well services. Again, there's a fairly strong negative relationship. So of course, these findings, due to our small size, do not control for any additional factors beyond number of services and cost per service. But nonetheless, there's some evidence that health practitioners may be able to recognize economies of scale in the production of these services, or potentially even other public health services. And so finally, I wanted to present you some preliminary findings about that focus on our cross-validation of our cost estimates. So as Nancy mentioned, we collected data using our survey tool, but we also are in the process of trying to cross-validate these estimates using other data sources. We started using administrative data from the North Carolina Department of Health to do so. And these are some preliminary findings. So we found that the cost estimates using administrative data were lower than what we found using our survey tool. Again, this is a preliminary at this point, but that may point to several issues with using secondary or administrative data for some of these costing activities. The most important, or maybe North Carolina specific issue that we were facing was that the way the state health department collected expenditure information did not really line up very well with the service lines that we tried to cost. So part of that difference that we can see here in the cost between these two instruments, or these two data sources, is likely due to the fact that we weren't able from the state health department to obtain really a full estimate of environmental health services cost. So that's definitely something that we'll need to explore further. And as Nancy also mentioned, we are in the process of having activity logs completed, so that will be eventually our third way of cross-validating our cost estimates. And now I'd like to hand it back to Nancy for some lessons learned and next steps.
Thanks, Simone. So as I also mentioned in New Jersey, adapting the SASCAP tool to make it usable for local health departments in North Carolina was a challenge. Generating these cost estimates was complicated by the fact that in many North Carolina local health departments, budget procedures do not easily lend themselves to splitting program costs. I don't think any of the health departments pay rent. And there is also difficulty in identifying indirect and overhead costs. So I think it's really just a different mindset in terms of what budgets are crafted for in health departments versus what researchers need in the way of data to do these analyses. In terms of implications of practice, increasing demand for accountability in public health service delivery and outcomes, though, suggests that that we need to take some of these, these budgeting and accounting procedures into account. Efficiency is a key consideration. And to the extent that local health departments want to do that in North Carolina, then there should probably be some revision around finance and accounting procedures in order to make these cost estimates as specific as possible and as usable as possible. In our next steps, we're in the process of compiling the cost estimates for every one of the health departments that participated in our SASCAP survey, and we're going to send them out individually to each county and ask them to give us feedback about their perceptions of how well our breakdown of costs line up with what they think their costs should be. As Simone said, we'll continue to cross-validate our cost estimates. And then finally, hopefully, we'll get to the point where we'll be able to examine the influence of different delivery system structures on the cost of delivering mandated and other essential services. I just want to mention, too, we've also had some really good response from some of the health departments, one or two of which have already on their own tried to determine what their costs are for some of the very same reasons that we have outlined here. And then finally, I want to say thank you to Robert Wood Johnson for funding this study, to our core PBRN team and our advisory committee, our local health department partners, but also our public health practice partners, our environmental health managers and finance managers who really worked with us to refine that SASCAP tool, and I'm sure pulled their hair out, some of them trying to get those finance costs for us. So with that, we'll conclude and turn it back over to CB. Thanks.
Thank you, Nancy. Thank you, Simone, and thank you for the North Carolina PBRN DAX research team, and also to the New Jersey DAX research team. Two very excellent presentations providing us with invaluable first-generation, essentially novel empirical estimates for the cost of these public health services. So let us move on, and we will now have two commentaries. And so let's just start with the one that I just finished, which is the North Carolina, to provide a commentary on the work that was done at North Carolina. We have Lisa Harrison, and after she's done, she'll be followed by Kevin Sumner, who will also comment on the work that was done at New Jersey. So Lisa and Kevin, you have the floor.
Excellent. Well, CB, before I get started, let me make sure I don't take too much time so that Kevin has enough time left too. Give me an estimate of my number of minutes here.
Yeah, so each of you have anywhere from, well, we're running actually pretty good on time, so anywhere from 5 to 10 minutes. So very much, there's a lot of flexibility. Go ahead.
I'll tell the folks in my room to give me the cut off, shut up sign, because I can keep talking about how much fun we're having both with this study and then learning so much about the costing piece that is really important. So here with me today, I have my environmental health supervisor, Wallace Vaughn, and our environmental health specialist, Chris Hedrick. And the two of them helped fill out some of that tool for Dr. Winterbauer and our research colleagues. and are teaching me every day in my third year as a local health director. So I appreciate that we've been able to have an avenue to look at the cost structure of environmental health services and other mandated services we hope to get to. But I do want to make sort of a practice-based point out there to those listening and to those who can share with practitioners alike that budgeting and costing are different things. And that's especially important to me as we presented to our Board of Health last night, our local budget. We know what we can spend sometimes on environmental health, but that's not always what it costs to do a really good job. So I do think when we're talking about these cost studies, it's really important to remember that difference, that sometimes what we're given to work with and what it takes to do a good job are different things. So this work in that regard is really important. Also, just an anecdote, here on my desk in Granville County, I have a birthday gift from my best friend who loves to get first edition books. That's her collection item. And so for my birthday last year, she gave me a book called Filth Diseases and Their Prevention, the first American edition of the Board of Health by James Campbell in Boston in 1876. And I just find it fascinating that we're still talking today in 2015 about the importance of sanitation and keeping our food separate from our sewage. that was important in 1876 in America, and it is certainly important today because, as Wallace will often tell people, the gift of environmental health and these services from a societally valuable perspective is that you can go get some lunch. Some of you, like us, are eating your lunch right now as you listen. And you can go get that lunch and bring it back and eat it at your desk without having too much fear of getting sick. So when we also talk about the cost of this work, it's important to remember the value of this work. And given how little actually relative to the value this cost is. So those were some of my points. I also want to build on something Simone mentioned in our limitations. I think it's really also important to realize how onerous data collection is from a practice-based level, but that doesn't mean that we always have the right connections to what the data is collected for, how it's analyzed, how it's kept up with across different local health departments within a state. Every state has different capacity for building databases, for maintaining them, for analyzing them, and for sharing back with those of us interested in what it says. So we found a real barrier there when we had to go knock on doors and ask for a common data source, even though we know at the local level we're asked to enter data about the services we provide, the inspections we do, the numbers of miles that we travel to get this work accomplished. So I think that's another really important point Simone made as a limitation that I've heard many other PBRN researchers mention is also common across the U.S. So I'll just give a shout out to that effort. And I heard an interesting presentation recently by someone in the western part of our state who talked about the onerous data collection versus the difficulty in getting it to work for you when you know what it is about. And she had the song in the background saying, "Turn down for what?" And her repetitive line was, "Data for what?" So it's just a wonderful way for us to be thinking about anytime we collect data and we ask people doing hard work at the local level to enter data, we have to have that sort of song in the back of our head, and we have to say, "Data for what?" And organize it well. So to me, as a practitioner, that's a take-home too. So I think I'll pause right there. That looks to be about 5 minutes in. I'm glad to answer any questions that you all might have from us at the local level in practice doing this work. If you have practical questions about inspections, about on-site, about food and lodging, and what it takes to get that job done, you're welcome to ask. I have the experts in the room.
Thank you, Lisa. And we've been encountering some technical difficulties with the chat window. So later on when we open the floor to the questions, just feel free to unmute your phone mic and ask the question verbally, or you can also just email it to us. So anyway, without further ado, I'd like to turn it over to Kevin to provide a commentary for the work that was done with the New Jersey research, DAX research team. Go ahead, Kevin.
Thank you, and thanks for allowing me to make a few comments, which are really going to emphasize, I think, the points that were made in both of the presentations. And I agree with Lisa that I think this information and the work being done is really important. And I want to preface my comments with that because as I went back and looked at my notes, and as I'm jotting down notes, I realized that most of them may be perceived, at least, as somewhat negative. And that's not my overall position. I do think that the work and the results are really important. But having said that, I do think that it's really challenging and difficult for local health departments to actively participate in this kind of work, both because, at least from many of my peers in New Jersey, they don't see the immediate value of the results and can't often translate it to their work. But more importantly, because even with incentives, and as you heard, there were incentives to participate in New Jersey, it's a real challenge due to the human resource constraints of the local health departments. And I've been noticing in this work and even in much of the other work and the accreditation activities and elsewhere that we define typically health departments as small or based on small, medium, large, et cetera, based on their size of population. And I'm hoping that this work can start to change that conversation to think about defining health departments not on the populations they serve, but on the staff size that they have. As you saw, often in the presentations, it's the workforce that is the largest piece of the cost of the public health work that's going on. And so I think we need to be cognizant of the health department size. And with those very small staffed health departments, such as mine with 6 employees, it's a real challenge to go back and gather information, collect it in the manner that's necessary to do the rigorous research that results in data that we can actually use. And so I think that my second comment is that then kind of may influence the results of the data that we're seeing coming out of the local health departments, either because they don't have the time or take the time to gather the appropriate data, or even consciously or subconsciously recognizing what the research is that's being conducted, not manipulating data, but maybe not recalling or reporting data, so that it influences. As those of us in small health departments, we're always advocating for more resources to hire more people and do more work, and so anything that we can report out that helps that cause, we do, and I think that sometimes that is reflected in the data that is reported in some activities, and I think that was particularly true in New Jersey. As you saw, the small health departments, we either don't recall or don't attribute some of the work we're doing to the specific activities that are being requested. I also think that reflects the differing priorities at local health departments. We have mandated activities, and we have activities that may not be mandated, but certainly should be accomplished by local health departments. And we also have, particularly in home rule states like New Jersey, priorities that are dictated by our governing boards. And so that may influence some of the work that's being done. Not that it's work that wants or should be done, but is being required by those governing bodies. And then I think to kind of end, well, let me say that with regard to the funding piece in particular, we often see these funding streams come through. We put in a lot of effort on particular activities, and then those funding streams either disappear or dwindle over time. And so as a specific example with us, and this was somewhat referenced in Polly's comments with working collaboratively with others, we may not capture all of that. We, through a collaborative in our area, received funding from the community transformation grants to focus on tobacco activities. It wasn't funding that was accounted for directly from my health department, but I was actively participating in those activities, wherein we were identifying and promoting smoke-free multi-housing units. And through that project, we were able to encourage and ultimately identify 3 multi-housing units that agreed to go smoke-free. and then the CTG funds disappeared, and there's been no activities since then. So we saw some progress. We got really motivated and anxious to continue that work. And when the dollars disappeared, we weren't able to continue that. So this type of information can really help inform, I think, if we can help us build the case to continue those funding streams, especially where the work is being done. But I think we also need to be careful to account for work that's being done collaboratively in a community as opposed to just specifically by that health department. And then finally, to end on a somewhat more positive note, I hope, I do think that this information can be really helpful in advocating, particularly for the human resource side of work. We have seen over so many years a decline in the public health workforce, and I think a lack of understanding and lack of value attributed to the human resources in public health, that if we can continue to provide the documentation that supports the need for the people to do the work, the really good work of public health, and the outcomes that can be directly attributed to those human resources, then that in and of itself is a really valuable outcome that local public health practitioners can use to advocate both locally in their department, statewide, and nationally for the importance of public health professionals.
Thank you so much, Kevin, and thank you so much, Lisa, for both excellent commentaries really on the challenges that really the research teams face in terms of the data collection and also in just the larger implications for the practitioners, especially in the local health departments, of how to use or translate this data to inform policy and decision making. So excellent commentaries and wonderful presentations from New Jersey and our North Carolina PBRN. So first off, I do want to apologize to everyone. There seems to be technical difficulties for those who wanted to write or post their questions in our chat box. It doesn't seem to be working. So there will be two options. One is as you post your questions, just unmute your phone and introduce yourself and direct the question to either New Jersey or North Carolina. Or you can also email us your questions. At the very end, we'll provide the email address for the center too as well. So the floor is now open for questions.
Yeah, I have a question. Can you hear me?
Yes, go ahead.
Yeah, this is really from CDC. And we currently have a project that we want to estimate the cost of the lifestyle program. So I want to ask the presenters and Lisa and Kevin, can you comment on how to use the budgetary information for the cost of the program purpose? So for example, on your budget you listed your FTEs. Will that all? How do you know that all are used for that service that you provided?
Go ahead, North Carolina.
So this is Lisa. I think there are different ways, as Nancy and Simone mentioned, that each health department keeps up with their budget. So that's one of the complications with collecting data like this across different health departments. But you're right, we certainly use our budget information and our FTE cost as the mainstay in some of the data that we looked at across the 15 participating local health departments. So often you'll see just Excel spreadsheets with the numbers of our total budget. In North Carolina, in our 2-county health district, with 100,000 population across the 2 counties, we spend approximately $600,000 a year on environmental health services in total. So what Nancy and Simone had to extrapolate out of that was just the food and lodging and the on-site sort of combination. So I'm not the data expert with how they did that, but we did collect all of that. Just another tidbit, though, based on Kevin's good commentary, it reminded me that sometimes when research looks at the per capita costs of delivering these services and others,
it's so important to include some qualitative connection to the rural-urban continuum, in my opinion. So even though our per capita cost, may tend to be higher in a less populous community, that doesn't mean the mandated service and the actual cost of delivering that mandated service in a rural area is any less important or any less efficient necessarily. So I think it's worth exploring a little bit more how we present some of those data well and include those continuum differences. But Nancy or Simone, do you have any other added comments on the data merging of budget versus cost?
I mean, I can maybe just add, I mean, what you said, Lisa, is absolutely right. And, we actually did not, ask for the budget and, try to produce cost estimates from that. We did have this, costing tool that we just very briefly described, and, we can share with you if you're interested. And obviously, local health, practitioners had to go back to their financial records or their budgets or to whatever records they're keeping to fill it out, but we did emphasize that we are looking for actual expenditure information and not just budgeted expenditures, which can obviously be a big difference. So I don't think I have, I don't think there's a straightforward answer for your question in terms of like how do you take a budget and make it into a cost information. I think you likely will have to complement that